As many of you know, I'm Alexis Johnson. I'm the social media manager here at RSDSA. I'm joined by Jim Roach, Executive Vice President and Director of RSDSA, and tonight's guest, Bethany Ranes, Dr. Bethany Ranes. Dr. Ranes specializes in mental health from the perspective of cognitive neuroscience, which is a bridge between neuroscience and psychology. Her work focuses on translational science, taking new ideas discovered in laboratories and helping turn them into effective therapies that benefit patients directly. Her current passions involve working on brain-based therapies for chronic health conditions, especially chronic pain. She also regularly collaborates with other health professionals to help develop neuroscience-informed interventions for behavior change and non-pharmacological treatment options for conditions like depression, anxiety, diabetes, cardiovascular health, and autoimmune disorders. She has previously worked as a lead research scientist for UnitedHealth Group, Hazelden Betty Ford Foundation, and the U.S. Army. Currently, she works as a consulting scientist for organizations and companies who wish to blend emerging science about the brain with accessible healthcare solutions in order to help bring a balanced mind-body approach to modern healthcare. As always, remember that while the information shared here is helpful, please consult your physician for personalized medical advice. So before we let Dr. Ranes take over, Jim, do we have any announcements?
Just a couple. I just want to encourage everyone to join our real or / virtual walk this year. It's going to be in June, and there's a link on our website, and Alexis will put it up there. Secondly, as I mentioned last week, we are going to look for stories of remission, and we really want to cultivate a sense of hope out there for individuals who are still struggling with this mysterious syndrome. But today, we're really excited about the neuroscience of pain, chronic pains. We're excited. So, Dr. Ranes, please.
Yes, and I do have the link to Dr. Ranes' slides in the description. I will put it in the chat to make sure that everyone is able to view them. And yeah, of course, I will post more about the events that Jim just mentioned in the chat, but you all know the drill. Please leave your questions in the chat, and we will make sure that Dr. Ranes is answering them as we go and at the end of her presentation. So we'll turn it over to you.
Thank you, guys. So I'm Dr. Bethany Ranes, and I think you guys all know plenty about me now. I do have a great passion for understanding how the brain works, which is still largely a bit of a mystery to us all, but in the last 20 years, there's been some really amazing advances in neuroscience, partially because we're starting to really better understand some of the functioning of the brain and how it's evolved. And a lot of that comes around our thoughts, our beliefs, and how they affect our more automatic, or what we often refer to as autonomic responses. And now that might be automatic behaviors and habits. But what's really fascinating and what's really starting to take off in the healthcare space is what autonomic biological responses that we have in response to different thoughts and beliefs. Historically, a lot of times, I think when thoughts and beliefs were brought up, they were the context of these sort of invisible, almost magical things. They were really difficult to quantify. And what we've realized is that they're really just sort of the lived experience of the connections of our brain cells, they're called neurons, going back and forth into our brains and activating these different specialized centers. When those things activate, when our brains light up, what we see under an fMRI, those are actually our thoughts. They're our beliefs. We can start to see things like daydreaming in an fMRI. It's really fascinating. And as we've understood this and been able to understand it, we start to see how a thought or a belief can actually result in very real physical symptoms. And so what I would like to talk about today is how some of that research has really advanced our understanding of pain and really started to shine a light. Jim used a perfect word. He said a mysterious condition. So many chronic pain conditions have been considered or documented as mysterious over the years. Doctors really struggle because they can't seem to find a clear structural explanation, even though somebody is experiencing very real pain. And, you know, in the past, this has resulted in a lot of problematic issues. One, just wrong treatments being used and having no effect, which can really be awful for somebody who's going through something. feeling hopeless, feeling, frustrated. It's also created a completely unnecessary stigma around a lot of chronic pain conditions and those that aren't clearly, linked back to discrete acute pain, some kind of clear structural cause. Anything from trying to accuse people that the pain is not real, that it's somehow their fault, that it's the result of mental illness, all kinds of issues that we are finally able to see, no, that is not at all the case. And actually, a lot of these chronic pain responses are the result of a very adaptive and understandable evolutionary response in our brains that just kind of went wrong. It's sort of in the wrong place at the wrong time. So I'm going to talk a little bit about that today. And I think more optimistically, I'm going to talk a bit about the therapies that are coming out as a result of these findings and how the science is starting to shape how we treat pain for a lot of people, and hopefully introduce some therapies that may be of value to you folks that are listening. So kind of starting out, and I don't know if you are following along with the slides, awesome. If not, you don't need to, hopefully. I'll be able to speak in a way that makes sense. But I'm going to talk really quickly about how pain is a brain issue. One of the things that I think is most important to say right out of the gate is that pain is real, and all pain lives in the brain, all of it. You could break your arm in half, and that pain comes from your brain, not your arm. And it's very important, I think, Dr. Howard Schubner, who is a big name in this area, he has a lovely quote. He says, anyone that tells you that your pain is not real is either ignorant, cruel, or both. And I just really want to, make sure, because I'm saying pain is in the brain, I don't mean it's a special kind of pain or that it's an unreal or less real type of pain. I want it to be very, very clear that any pain you've ever felt and that anyone's ever felt in their lives has always come from their brain. And in a healthy person, the way that pain works, it has two primary components. This is really, really common in any kind of neuroscientific, phenomenon. First of all, there are the bottom-up components, and then there are the top-down components. These are really common phrases. Neuroscientists like to throw these around all the time. So the bottom-up signal is the signal from the body that goes up to the brain whenever there is damage that has occurred to our tissue. The fancy word for this is nociception, and sometimes that's referred to as nociceptive pain. The top-down is the brain's automatic response to those signals, and that's what we just generally refer to as the feeling of pain. So when something hurts, whenever you are in pain, that's the top-down signal that you're feeling. So these two signals are independent. They are related, but they are separate. Now, that means that nociception does not always have to occur for pain to occur. And whenever pain occurs, that doesn't always include nociception. So you can have one and nociception can occur without pain. So, these things, while they do often occur together, they are not necessarily the same. So they can occur separately as well. And that is probably the biggest realization that has opened the eyes to a lot of pain practitioners and pain patients, and understanding that, okay, like just because the doctors can't find something in my body that explains this, it doesn't mean my pain isn't there, which is, I think, a very important and exciting thing to realize. So if pain is happening when there's no damage in your body, how do you fix it? And that's a problem, because traditionally, for decades, centuries, we've assumed that pain lives in the body. And in order to get rid of the pain, we have to treat it at the source, which we always believed was the body. And so, what is problematic there is that, whenever there is no clear source in the body, we don't know what to do. And that's led to a lot of issues where then let's just block all signals from the body. Let's try something that blocks, signals, up through the spine. And you start to get into these very invasive therapies. You start to get into, a lot more extreme therapies. And a lot of times you'll have two outcomes. One, they don't work at all, or two, they'll work for a while, but, mysteriously the pain will come back. And doctors will be completely flabbergasted. How could there be pain when I've blocked any kind of nerve signal coming through here? I think one of my best examples of this is phantom limb pain, which is sort of the ultimate test of this concept. You can actually lose a limb, so you've lost all nerves, all tissue, all everything, yet you can still feel pain, itching, all kinds of uncomfortable feelings in the limb that used to be there. How does that work? So the way that you can think of it is that pain is activated by other parts of the brain in a lot of cases. And the main part of the brain that is to blame, I feel like I sound like Dr. Seuss there a little bit, is the amygdala. You may have heard that term before. It's a pretty popular part of our brain. It deals with threat, and it can deal with novelty. It's what makes us alert and aware when something lights up as a potential danger. Our amygdala usually activates a lot of our fight or flight style responses. So it keeps us ready, keeps us alert on anything that's a threat or could be a threat. And so people who have what I refer to as non-structural pain or chronic pain that's resulting without any clear source in the body have been found through fMRI to have hyperconnectivity between the amygdala and the brain's pain processing centers. And what's really interesting about that is on top of that, that connection is naturally stronger in women than it is in men, even in healthy people who have no chronic pain, which is, kind of a potential explanation for why we often see a lot of these pain conditions with a slightly higher rate of women who experience them than men, because that amygdala connectivity is naturally biologically a little bit stronger in the female sex than the male for some reason. So in English, what does this all mean? It means that the brain has learned to associate danger, negative emotions, and pain in somebody who has these chronic non-structural pain issues. So whenever that amygdala lights up, there might be a threat, there might be danger. It's also activating the pain center. So it's immediately starting to activate a pain response in a result. And so when stressful or scary situations start to occur, then the amygdala is going to activate the same top-down pain signals that are activated by nociception whenever you have tissue damage in the body. So in other words, as the person who's experiencing this from your own perception, the exact same pain is going to occur as though damage were occurring in that part of your body, even though it's not. It's going to feel, completely identical to you. Now, what's fascinating, what we see really often with pain, just by the nature of it and the nature of our beliefs about pain, when it's learned, so when it occurs because of that amygdala, that increased fear or stress, then we tend to associate it with some kind of harmless signal from the body because we assume pain must be coming from the body. Oh, I'm seeing a note here. Are they supposed to be live? I mean, they can be, they don't have to be. I can pop them up here. If I'm allowed to share my screen, I can most certainly do that. And if not, it doesn't make a huge difference. Let's see, apologies. It looks like it wants me to quit Zoom in order to share my slides. Oh, nope, that is not true. Let me just change this. Apologies all. Okay, is that showing up? Woohoo! Okay, great. I'll leave the chat open too, just in case. Just in case there's something else. Okay. So yes, when pain is learned, we assume it has to be coming from our body because that's what we've learned our whole lives. That's what's been reinforced. That is a strong belief that is held by just about every human on earth. So when you feel that pain, you're going to associate it with some kind of harmless signal that it happened at the same time. That could be movement. So maybe, I moved my arm or my neck in such a way. It could be your environment. So I've been sitting a long time and that's what's causing the pain. A lot of people believe that weather affects pain, even though there's no actual biological or physical explanation for how that would be so. But it's a very commonly held belief by people. So when it rains, it makes my back hurt or it makes my knees hurt. When I do this, when I go there, and a lot of times it is some kind of movement. It's some kind of way that you're holding your body. So we start to associate that with the pain. Now, what's unfortunate about that is that in doing so, we create a feedback loop. So if we associate that thing with pain, anytime we do that harmless signal, anytime we encounter it, then it will actually activate our amygdala and create the pain signal all over again, which is now reinforcing that belief that they're connected and actually creating a connection that really shouldn't be there at all. If you guys are familiar with Pavlov's dogs and the idea of a tone and salivating, how you can use something to train an automatic biological response, you can kind of think of it that way. That signal then does start to activate pain, even though there's no real damage occurring. There's nothing dangerous about it. It's just a learned association. And that makes a very real pain response. And what's also very interesting, you do see it sometimes in chronic regional pain syndromes, but you also see it in other pain syndromes. Multiple signals can start to get involved. So whenever you maybe start to, fix one signal, another one will pop up and that'll cause pain, or it may jump around in your body. It may kind of feel like it's a moving target. And that's a really strong indicator that you've got multiple feedback loops of learned signals going on in your brain. And so, what's really important in dealing with these kinds of conditions is moving away from the belief that you need to do something to your body to change them, because that is the inherent nature of the pain. When you're dealing with these kinds of conditions and you've ruled out all of those physical causes, now we know we have to focus on that top-down signaling. We have to help train our brains to know that our bodies are safe, that we're fine, and that pain is coming from something else. The way that we've been doing that recently through these new brain-based therapies is kind of looking at it similar to exposure therapy. Some of you may be familiar with that. It's when you use a therapy to extinguish a fear in a lot of cases. What brain-based pain therapies are doing is using it to extinguish that connection between the harmless signal and the pain response, trying to reduce that amygdala activation that happens when we're scared, and kind of bring down that pain signaling so that you can actually achieve not pain maintenance, not changing your beliefs about your pain or reducing any kind of fear of pain, but actually literally stopping that pain activation itself. So you get pain relief as opposed to, a change in your pain beliefs. That is a very new concept. The whole concept of this is based on the assumption of what's called neuroplasticity. Jim and I were just talking about this before we got started. So about 20 years ago, it was commonly believed that once you reached adulthood, your brain was set like concrete. And we realized that is not at all the case. Old dogs can learn lots of new tricks. We are constantly changing the connections in our brain. Some of them are definitely a bit more strong and resistant to change than others. And those are often referred to as like core beliefs, but they are not immune to change at all. And so these brain-based therapies are based on the idea that what can be learned can be unlearned. So any associations that have been created over time through your experiences and through your life, you can unlearn them as well. You can extinguish them, just like you would a phobia or any other kind of change of a habit, because that's how our brain is designed. We're meant to be adaptive. And so we're working with our biology as opposed to against it here. And these initial studies have really shown that brain-based therapies aren't just creating a change in patient-reported pain, although they are. We actually can physically see the changes to the brain that occur when they've been done. So what we're seeing is a reduced hyperconnectivity from the amygdala. So when the amygdala lights up, maybe you're threatened, sure, but it doesn't activate your pain centers anymore. You also see connectivity from the prefrontal cortex. So that's kind of our thinking brain, our rational brain. And that is increasing the connectivity into the pain center. So it's slowing down the activation from the amygdala. And what that usually represents is some kind of conscious thought, some kind of conscious effort to calm yourself down and reassure yourself of safety, and it'll reduce that activation. So that's kind of a cool thing to see in an fMRI. And what's most important is that for those who respond, for those folks who are dealing with this chronic non-structural pain, these therapies demonstrate dramatic pain relief. So pain reprocessing therapy is a very common therapy. It was just recently published in JAMA, its first big clinical trial. And for people who had been experiencing chronic back pain for over a decade, 66% of them in a 3-month period achieved the state of being pain-free or nearly pain-free. And at a 1-year follow-up, it was kept, the effects were strong, even without any therapy in the interim. So those effects stayed for a year, not only in their reported pain, but also in the connections in their brain that we saw in the fMRI, which was very exciting. So once something is in there and it's reinforced, it's very, very effective. Okay, so sounds like I've just described the perfect cure for chronic pain. It's no longer a problem, everything's fine. No, unfortunately, there are some things to consider. There are some challenges around this, and I want to be very transparent about those. So the first one is pretty obvious, I think, based on the description. They don't address damage. If you break your arm, then it's not appropriate for you to do any kind of brain-based therapy while that arm is healing. So in order for the exposure therapy to work, in fact, we need to make sure there are no structural damages in the body, because the point of the therapy is to reassure yourself of a state of safety. I like to say that a fear of bears is going to be pretty legit when a bear is actually chasing you. You don't want to sit there and have a mindfulness practice to reduce your anxiety if you're being chased by a bear through the woods. And so it looks as though, for those folks who are wondering, well, I mean, how many people actually have this non-structural pain? Is it rare? It is not rare. It seems that even though there's still some debate among pain providers, because there are a lot of things that have historically been tied to pain that we are finding don't actually have a strong relationship or correlation to pain, like herniated discs in the back and things like that. A very large portion of chronic pain is non-structural. So if your pain has lasted longer than 3 months, there's a very good chance that even if it was originally due to a structural bit of damage, that your body can heal. And in a lot of cases, the pain it has become learned, as opposed to being a live, sort of feedback of nociception. So, there are studies that have estimated that approximately 85% of chronic back pain has no definitive structural cause. So there's a very large number of folks for whom this is an effective strategy to address your pain. These are still new therapies, and they're still being tested. Even though early studies have been incredibly promising, you have to remember that there's not as much research backing these up as some of our more established therapies. CBT has been around since the 60s. It's got tons, and it was literally designed to be tested and to be researched easily. So there's tons of research there. We have lots of really strong effect sizes. So we are seeing some really great promise in early studies, but just be mindful that we're still learning about them, and it's likely that they're going to evolve and change a little bit, so that we can learn more about who's responding and why, so that we can really kind of maximize their benefit for people. Sorry, just reading the question from the Q&A. Dynamic allodynia and the best brain training for this. Some doctors have stated that brain training will not work with allodynia because the actual nerves are crossed, and therefore the pain may be structural. What do you think about this? So this actually speaks a bit to what I was saying, when there can be some debate sometimes. It is tough to know, is my pain structural or is it not? Because there are a lot of times things that are very strongly correlated with pain. And the only way for us to know whether they are consistently structurally the cause of pain is to test people who don't have pain and also have that structural abnormality. And that is still in very early stages in a lot of neuroscience research. It's mostly been focused on the back and the spine, because there were so many misconceptions about spinal abnormalities that are actually a very normal part of aging that a lot of people have that have no pain. So we realized, oh, okay, this doesn't actually automatically result in pain. I can't speak specifically to allodynia in this sense, because again, we haven't hit all of them in major research. I will say that brain-based therapies can be extremely effective, and they have a very low risk. These are talk-based therapies, they're psychotherapies. And so I would say, if you're not sure if your pain is structural or not, finding a therapist who does do more of a brain-based approach is not going to be anything that harms you, and is most certainly worth the effort to talk to them, to speak to them about what you have. A lot of times it's a very personalized thing, and what a good provider will do is sit down with you with your past scans, all of your medical history, all of the sort of evidence that you have about your condition, whether or not it might be structural or not, and help you go through that and determine, is there evidence for a non-structural issue or is there not? So it is something that can tend to be at this point still fairly personal, but it is usually the first step of a good brain-based therapy session is to sit down and really go through and rule out or rule in whether a structural cause is causing your pain. Ooh, I like this. What if you have both structural and neuroplastic pain? That is a really, really great question. A lot of people do have signs of both. And I would say that the answer is somewhat similar here. So these brain-based therapies are talk therapies, and they largely have very little risk. You will have some therapists who practice and they like to keep things really, really clean. And they say, I don't like to work with people who have any structural damage. And you have other therapists who realize we live in an imperfect world. Very few people are like perfectly aligned with exactly what you want to see. And a lot of people do have signs of potentially having a little bit of structural and non-structural pain. And there are a ton of therapists out there who are very comfortable doing brain-based therapy, even with that kind of complexity in your case. So similar to the person who spoke about allodynia, I would reach out to somebody who does specialize more in these kinds of mixed signals, because a lot of times it is a case of both and it's not exactly perfect. You may have some nociceptive signaling happening, but your brain may be really enhancing that signal. You may be adding on to it from the amygdala activation, and there are things that you can really do if you don't get completely pain-free to really get your pain down quite a bit by working with a brain-based therapy or working with a brain-based therapy. So I would highly recommend checking it out, because it's not like a pharmaceutical and it's not like a surgery where you have a lot of risk in doing so. And there's really a lot of really great opportunities for most folks. As a sidebar, I mean, I guess I can say too, just on a personal note, something that I really did for myself while I was in labor with my daughter. I knew it was going to be structural in nature, but I also wanted to make sure I was just very clear on the biological function of everything that was going on during labor and all of the components of labor and what it does and why it does that and how it helps with the baby being born. And I really educated myself on all of the physiologic processes that I could get my hands on, really understanding exactly what all the feelings correlated to, so that I could really help. Now, of course, it doesn't make the experience pain-free by any means, but it helped me to manage my pain during what would be an obviously very structural pain process by doing so. So you can really kind of combine these aspects and find something that works for you. One thing that can be very frustrating is that brain-based therapies can be difficult to access. So they are psychotherapies, which in and of itself can sometimes be difficult to get your hands on or have insurance cover. One thing that can be difficult is that most doctors have very limited training in neuroscience, and they actually have less training on the science of pain on average than your average veterinary medicine specialist does. So your vet that you bring your pets to has likely had significantly more hours of pain education than your own physician has, which is insane. So sometimes it can be difficult to talk about these therapies or get these therapies from a traditional biomedical treatment, clinic. So training providers is definitely ongoing, but it's going to take a while. While insurance doesn't yet cover a lot of these therapies, they are very interested in these therapies. So I've worked for a major commercial insurance company in the past, and there's a lot of interest in these therapies, and there's a lot of work being done to figure out how to make them much more accessible to people, make them much more frontline. Sometimes we refer to them as for people who are struggling with chronic pain. So I encourage you, while it can be difficult to access them right now, have hope that it is getting better, and it's getting better quite quickly. So here are a couple of specific resources for anyone that would like to learn more. So these are all kind of like DIY resources, because what's really cool about a lot of these practices is that you can get started on your own. You do not need to see a therapist in order to get started and to practice them. A lot of these things can be done, just kind of practicing on your own, kind of like a mindfulness practice almost. So there is a book on pain reprocessing therapy, or PRT, which is a very famous brain-based therapy that's by Alan Gordon and Alon Zeev. Unlearn Your Pain is a workbook, and it is based on something called emotional awareness and expression therapy, EAET. Wanted to make sure I got my E's and my A's in the right order there. Dr. Howard Schubner has developed that one, and it does have that interactive workbook. So it's good for anybody who likes to kind of get the pen to paper and do some work there. Hidden from View is a book that was written actually to help medical providers understand brain-based pain and therapies, but it can be really, really helpful for you as you're learning and trying to understand your own brain and your own condition. And finally, Curable is a website, and it has a ton of resources. A lot of you may already be familiar with it. They tend to have many, many resources on brain-based pain, and there's lots of webinars and podcasts. Alan Gordon does podcasts called Tell Me About Your Pain that are all about PRT. There's Like Mind, Like Body, which does a lot of podcasts there. I've actually done an interview on it talking about pain there. So I highly recommend Curable for folks as well. I also just wanted to talk really quickly about, some examples of adjunctive therapies that can make, so a top-down, brain-based pain therapy, they're largely going to be psychotherapy. They're talking through, and that's how we change our beliefs. We have to sort of be convinced and convince ourselves. So we can do that in psychotherapy. But there are things that you can do alongside those therapy sessions that are very, very helpful. And I like to call them neuroplasticity enhancing therapies. So some of them are more intense and they have a very significant effect. Probably the most intense effect is going to come from psychedelic assisted psychotherapy. It's obviously still very experimental. It's not available everywhere. Ketamine therapy is available, but it can be very expensive and hard to get a hold of. These are therapies that psychedelics chemically change our neuroplasticity in our brain. They change how our brain's chemicals are working, and they make those connections between our neurons, even if they're really strong and really established, softer and easier to change. So when you do that, you can really get into some core beliefs and change them much more rapidly than you could if you were trying to do psychotherapy just by itself. And so it can be really, really helpful for anything like pain, where you're having something where a belief or a sense of fear or threat is automatically creating a physiological reaction like pain. So it can be very helpful. Anything that's that automatic and unconscious tends to be very, very strong and can be difficult to change. There's also TMS, transcranial magnetic stimulation, which works. The mechanism is still under investigation, but it also enhances neuroplasticity. So doing TMS alongside therapy works in a similar way as the psychedelics. It's just at a smaller level, a less dramatic level. And that is also the case for eye movement desensitization therapy. So that eye movement also has an impact on our neuroplastic potential and can make therapy a bit more effective. It's also calming, and so it's really helpful for trauma processing, which is a very common thing that's needed for chronic pain. A lot of times folks with a trauma history tend to have an amygdala that is particularly sticky and loud in their brains, and it's really kind of assigning threat status to a lot of things in the environment that are not actually harmful. And then lastly, there's a lot of lifestyle interventions that you can do alongside these therapies that can make them very helpful, largely around exercise, which is huge. It can be difficult when you have a chronic pain condition. So whatever you can do, it's not like you have to run a marathon, but just whatever you can do to be active and to get that heart beating and kind of get that blood flowing the best you can. Doing that on a regular basis will increase your just general neuroplasticity, as will mindfulness practices. So those of you guys who haven't looked into things like meditation, yoga, things like acupuncture can be very helpful as well. Just something where you're slowing down, you're focusing on just the present moment, particularly focusing on your body and trying not to focus on feelings of pain, but focusing more on a non-judgmental lens of your sensations and perceptions. This can be very helpful for these therapies. They're not always therapies in and of themselves. So if you've tried them before and they didn't make you feel better, fear not. It's usually because they're a bit more of like a helper, not the therapy themselves. They're the potatoes and not really the meat in a lot of cases. For some folks, they work and that's amazing. But for some folks, they usually need a little something on top of those therapies in order to get what they need. I also have, and I don't know if you guys can see them here, I have some links. If anyone's interested in finding some therapists who do this, I do have some links to directories that will help you to find people who are brain-based practitioners in your area. So I will go ahead and put that in the chat for you guys. The first directory, for whatever reason, somebody asked me if I could find somebody in Maryland, and I think my link got stuck on Maryland, but you can clear that out, and you can, let's see here, and you can clear that for yourself. So let me just get this here. Make sure I've got all of the information correct. I do. There we go. Okay, and everything else here is just references. If anybody's interested in any kind of articles, I have them here. They're in the slides if you want to look at those. And if you have any questions about anything in particular, I'm happy to share articles or talk about them, whatever is useful for you guys. So I think that's it for my slideshow here.
Awesome.
Okay.
Awesome. Thank you so much. I'm going to bring Jim back on as well. Everyone over on Facebook, you all know the drill. Be sure to continue to leave your comments in the chat. Your last slide just answered one of our questions. Of course, we've heard a lot about curable, but we did have some questions about, where they can find therapists to help with brain-based therapies, but those links should definitely be helpful. And I know you mentioned earlier about ketamine, and we do have a ketamine list, but I know there are tons of different ketamine lists and resources out there. So do you have like a go-to, I guess, like place to find physicians who can actually help with ketamine?
I unfortunately don't have that as readily as I do for the others. I only know of a few places. I just overall, I encourage people to look for a place that does ketamine-assisted psychotherapy and not just ketamine. That's becoming pretty rare, so it shouldn't be too difficult. When ketamine first started to gain some traction and popularity for depression and for other sort of chronic brain-based conditions, sometimes people would just get ketamine infusions and they'd be like kind of left in a room, and that was that. It was like, treating it like a pill. And again, that's actually an adjunctive therapy. You really need the psychotherapy. So what that does is it sort of like cleans off, the map, but you still need to redraw the new pathways, right? So that's really important. So whoever you do go to, make sure that you kind of ask some questions around the therapy that they're doing and make sure that that's the focus of the therapy and not just the ketamine itself. But again, I think that in the last couple of years, that's becoming more and more obvious to providers that you really can't skip that step. That's the critical step. I also tend to be skeptical about any kind of drug. And again, these are losing a lot of steam, but any kind of drug that's ketamine without the psychedelic effects. The psychedelic effects are actually your brain's lived experience of those connections loosening and becoming more flexible. If you're not having that, the neuroplasticity effect is not going to be nearly as effective. So be a bit wary of anybody who claims to have a drug that will allow you to take ketamine but not have the psychedelic experience. While that can be effective for certain conditions, in a large scale, it really is taking the mechanism of action out of the drug. So as much as it can be a little scary, I encourage you to talk to somebody and learn about it. It's completely natural to be a little nervous about that. And if it's not the therapy for you, that's okay. There are so many other things you can do, and don't feel like that's gonna, be the only option you have.
Awesome.
I was wondering that what if you have an old school doc that's not really familiar with the neuroscience and the brain-based therapies, and you, in your 15-minute segment with him or her, what do you do?
Yeah, it can be very difficult. I think that what I hear from a lot of people, it's really tough to sort of be embedded in a system that is very biomedical, old school, as you say, and to find answers in that kind of a system without some help somewhere else. So I would encourage that you ask that provider, can you provide me with the evidence that you have that there is a structural reason for my pain, right? That it's in my body. They may have something, they may not have something. And you can take that evidence and talk to somebody who has a specialization in more of a neuroscience informed therapy and just say, hey, here's what my doctor gave me. And I don't know what to make of it. And can you help me? And a lot of them are more than happy to. And in fact, like I said, the first session with a good brain-based therapist is likely to be something very much like that. Let me see everything you've got. Let me see your MRIs. Let me see all of your records that, you know, if you're comfortable sharing that, so that they can go through and help you understand what they mean and understand where it makes sense that that could be the source of structural pain or not. And sometimes it's really tough. It can be very ambiguous. And you know, 15 minutes, right, with that doctor is not a whole lot of time, and it's really difficult to evaluate for yourself. So I would just say kind of create a bucket of evidence for yourself and work with somebody that does have this neuroscience background. I promise you, there is nobody out there who is going to tell you you have brain-based, you know, a neuroscience-based pain condition when you don't. There's nothing for them to gain out of it, I promise. And so, you know, they'll let you know, this is purely structural. I can't help you here. There's a lot of, there's a lot of things to take into consideration. So don't be afraid to reach out for help and just ask, am I a good candidate for this therapy?
And you mentioned psychedelics. Are they available anywhere other than clinical trials?
So ketamine is available. It's an FDA-approved drug. So that one you can get. It's being used off-label for mental health for this neuroplasticity effect, but it is something that you can get right now from a ketamine provider. And the number of folks who do ketamine-assisted therapy is growing every day. For other psychedelics, the MDMA and the psilocybin, you're going to have to be part of a clinical trial. The best way to learn about that, I think the biggest directory right now that's a good resource for that is called MAPS, M-A-P-S. And MAPS is, I believe it's MDMA. I can't remember if it's MDMA and psilocybin, but it's a giant directory of psychedelic trials for various conditions. And it's a really great starting place if you're interested in that and you don't know where to find it.
Good answer. Thank you.
Yeah.
We just had another question come through. I want to make sure that I do butcher that phrase. So I want to copy and paste it.
Dialectical behavior therapy. I love DBT. So DBT, it's what is sometimes referred to in CBT has been around for a long, long time, and that's what most people are familiar with, cognitive behavioral therapy. But it's very broad. It's not very precise. It's not very specific, and it doesn't take into account the physiological side of our brain's impact on our bodies. So it's not always as helpful. It's very in your mind. So there's something called the third wave CBT practices, and that's where you see things like dialectical behavior therapy, which is all about holding two opposing thoughts in your mind at the same time and being able to work through that cognitive dissonance. You also see things like mindfulness-based CBT. And so there's a lot of really great therapies out there. And it could make sense that dialectical behavior therapy could completely eliminate your pain. It really just kind of depends on what you're working through. One of the things that a lot of people will find is, even though they're not working on their pain, if you have a history of trauma, which is common to have DBT in that setting, working through your trauma, finding that peace and getting through there can really change your amygdala activation patterns. So even though you weren't trying to treat your pain, you can find that you'll have a significant reduction in pain and other somatic symptoms by processing long-held trauma or major stressors, core beliefs that were causing persistent anxiety. Anything that can kind of slow down that amygdala response can often have a very positive influence on your pain, even if that's not what you were trying to do in the first place. So does it make sense? Sure, it can make sense. It depends on your situation, but it's not like that has absolutely no basis in reality whatsoever. So I would say there are a lot of situations where something like DBT could help eliminate your pain. And if so, congratulations. That's wonderful. That has to be a wonderful feeling.
Yeah, follow-up comment says the DBT compassion, mindfulness, and skills somehow took all my pain away. So
yes,
really good to know.
That makes a ton of sense. Yeah, compassion, mindfulness, and that, again, that being able to hold two opposing thoughts, I hurt, but my body is safe, is technically something that you would be able to practice through something like DBT. So even if you then wanted to apply, if you're familiar with DBT and you'd like to apply it to chronic pain, that's a great place to start, is just knowing I am in pain, but I am safe. And that can really help to extinguish the connection between that fear and that threat And what I'm doing is causing damage to my body, and then the feeling of pain that comes with that. So if folks out there are familiar with DBT, you can sort of, work on those thoughts as a starting point. But, that's something to think about.
Awesome.
Really love your excitement. What's happening in the future? You're on the cutting edge of research. Anything that we should be looking out for in the future?
Yes. So what I think you're going to see in the future is massive scaling of these therapies that are starting to gain traction now. So I know I'm pretty close to development in the PRT world, pain reprocessing therapy. And the biggest goal right now is getting it out to as many people as possible and making sure that it is as effective for as many people as possible. So I think you're going to start to see a lot more folks that are doing trainings around these therapies. So you're going to see more practitioners who are able to do them. I think you're going to see a lot more resources, both digital and potentially, books and things like that. So I think you're going to see a lot more apps. You're going to see a lot more programs that your insurance is going to be able to support. So I do think that we're at the precipice of a big paradigm shift on pain, and this understanding that you don't always have to go into the body. And in a lot of times you don't have to go into the body. I think it's going to be important that we have a lot of education and awareness and compassion, because the last thing I want is for people to think that we are dismissing pain or dismissing anything by saying this. One of the concerns I get a lot is that, brain-based therapies are telling you just to think positively and to think away your pain. And that's not necessarily the case of what we're trying to do here. And so I think it's also going to be a lot more education and patient-based communications and advocacy to make sure that as these things are scaling and as they're becoming more available, patients understand what they are, how they work, and kind of what they are and what they aren't. So I would imagine you're going to see a lot more of that as well.
All right, we do have a few more questions. So someone asked, what about the brain fog that comes along with CRPS? What can someone do for that?
So I think what's really fascinating to me in a lot of these conditions, and why I'm really so jazzed about not just brain-based pain therapies, but just understanding this kind of threat activation on the body's automatic systems in general, is that the symptom list of what can happen when you have an amygdala that's gone a little bit off the rails is long. And it's all over the place. And cognitive fog is most certainly on there. So with cognitive fog, what you're going to see, one of the things that happens when we are in fight or flight or any kind of a threat activation mode is you tend to have a reduced activation of that part I talked about earlier, your prefrontal cortex. Boop, the smart guy that lives up here, the last thing that we had to evolve, our rational thinking mind. It's where a lot of our executive functioning, attention, everything that we kind of think of as like more conscious cognition occurs up here. Well, when you have heightened amygdala response, and that happens, before and because of the pain, just like I said, that feedback loop. So if you're having a pain episode, your amygdala is going to be firing on full blast. And what it does is it starts to reduce, your brain only has so many resources, and it's trying to kind of put them where it can. So all your resources are going into that threat activation. So whenever you're able to kind of work through this and you understand what's happening in your brain, I mean, so much of this is education and finding a way that makes sense for you, how your brain is working and how it's affecting your body. But that is going to also help with that cognitive fog aspect as well, because it all makes a lot of neuroscientific sense. It all makes sense on the function of how our brains tend to work. In the meantime, I think one of the best things you can do in the short term when you're experiencing cognitive fog is to just, if you, again, kind of getting into that mindfulness, but if you can sort of increase what we call your parasympathetic activation, which is your rest and digest, right? One thing that a lot of people find a lot of luck with, it sounds so simple, and I almost like hate saying it in talks like this, but it is so effective, is your respiration. If your exhales are longer than your inhales, it is one of the fastest ways to activate your parasympathetic activation. So if you have a breathing app, you can use your Apple Watch, you can use a meditation app like Headspace or whatever you may have. It can really help you've got to calm yourself down for any of that to work, and it's all automatic. So in order to calm those signals down, you can't really just tell yourself like, stop that. As much as I'm sure you wish you could, you've really got to come at it biologically, and breath is really the quickest, easiest way to do that. But anything that you can do that helps kind of reassure your body that you're safe is critical there. And you should see some improvements pretty quickly on that. And it will get more and more effective and more dramatic over time as you practice that. But that cognitive fog is just another survival response that your brain has.
Wow, someone commented said, "Thank you. I didn't realize that was part of my fight or flight." So
it is, yeah. I mean, and so many of these things, kind of getting back to compassion, someone said compassion. And I really just want to point out, you guys, what your brain is doing in these conditions is frustrating, and it's in the wrong place at the wrong time, but it's also very amazing. This is all part of a survival structure. So having some peace and some compassion, and knowing that like all of these things are tied to a system that has kept your species alive for eons, and what we've kept through evolution. It's unfortunately right now kind of in the wrong spot, right? You're in a Ferrari in a suburban road as opposed to like an open highway, but you know, that doesn't make the Ferrari any less of a magnificent vehicle. So having some forgiveness and some compassion and understanding that all of this often comes down to your brain thinking you are unsafe and trying to keep you safe. So just remembering that and having a little bit of compassion can also really help, I think, when things get frustrating, is just remembering that your body's just doing its best and your brain's doing its best to keep you safe and alive. So yeah, absolutely.
right. Well, we have a couple more questions before we wrap up. One of these questions, but they're both great questions. I always say that, but they're both great questions. This first one: I work on my feet all day and I have CRPS in my foot. How can I explain my condition in a concise manner to my employer? I can't find a quick and articulate way to explain.
Ooh, that's a really great question. And likely what's happening is your feet are definitely feeling tired. They're feeling the load of that. You may not have, if you've ruled out any kind of structural damage, you don't have any kind of broken bones or anything like that, and it's CRPS. I think just letting your employer know that you're working through a condition right now, but that your brain is taking the signals from your feet, being tired, being worn out, working really hard all day, probably the stress also of a hard day. And it turns on the pain center in your brain, just like it would if you dropped something on your foot. Let's say you dropped a big cast iron skillet on your foot, or you dropped a heavy piece of equipment on your foot. That pain is what you are feeling because it all comes from the same part of your brain. And right now you're working through a situation where the tired feelings in your feet and that stress from your day is activating that without the cast iron skillet. And hopefully that'll help your employer have a little bit more sense of empathy of what's happening. And I hope that helps you also know, I mean, it's all the same. So you are feeling that pain, even though the damage isn't there. And it's just a matter of working through that and taking the time to know, feet, I know you're tired, and body and mind, I know you're stressed, but I am safe, and kind of getting through that for yourself. But I would explain it that way, and hopefully your employer understands.
Yes, it's a question that we definitely get often. So I always want to make sure I get different perspectives. So I'm not sure if you have another question, Jim, but I definitely want to ask this one, and then I can turn it back over to you to wrap up. So this person says, how do you get help when you are homebound 98% of the time? This person has CRPS and many other related conditions that we typically see when folks have CRPS. They also mentioned that they're open to trying mushrooms, but they don't like the high feeling that you can sometimes get from mushrooms because they also have PTSD.
Yeah, absolutely. Really great question. And yes, thank you for touching on the comorbidity piece, which is, like I said, when you have an amygdala off the rails that like is hit and threat all over the place, the symptoms go far wide and high. And so since we tend to diagnose a lot of things based on the symptoms that you have, it's likely that you start to have a laundry list of these disorders that have a very similar likely root cause. So thank you for bringing that up, because that's something I didn't really mention, but for those who are experiencing that, that's a big part of why. Your amygdala has control over a lot of processes and systems in your body. But to your question, actually brain-based therapies are largely done through telemedicine. You do not need to be in person to do them. So there's a very good chance, if you want to take a look at the links that I set, or if you want to do something like Curable, or you want to do something like a book, like Unlearn Your Pain, you can do all of those from home. There's absolutely no reason that you need to leave your home. all of these folks who are doing brain-based pain work commonly with people who have things like CRPS and a lot of the comorbidities that come along with chronic pain syndromes. They're 100% used to patients who are homebound and are completely compassionate to that and will work around that as best as they can. So it may be that as you progress in your therapy, if you're responding well and you're doing well, they'll encourage you to practice kind of getting out and doing more just as part of that exposure and teaching you there. But that would all be done very carefully and as part of your therapy. But 100% you can access these things through telemedicine and access them remotely. And as for the psychedelics, unfortunately, that feeling of becoming disassociated and kind of being separate, that feeling of high, as you say, is largely going to be kind of the mechanism, what makes those drugs work. However, if you do have a history of trauma, I wouldn't necessarily recommend mushrooms. I would look into MAPS because MDMA is actually much more well suited to folks with a history of trauma. And that's where they're looking at. So they have PTSD patients and the other trauma disorders and issues in that realm. So MAPS would be a really great resource for you. And I would encourage you to check out what you can do around MDMA.
A lot of that research is coming from the Veterans Administration, I believe.
What's that?
Is a lot of this research coming from the Veterans Administration because of the trauma of our returning soldiers?
I mean, it's not entirely from the Veterans, Administration, but certainly a large part of it is just when you're dealing with PTSD, that tends to be where most folks' minds go, just because it's so ridiculously prevalent and tends to be quite severe in a veteran population. But of course, you can have PTSD in non-veteran populations. And honestly, what we're finding is that I always refer to big T trauma, which is what we often associate with things like PTSD. But there's also little T trauma, things that are just like a difficult, fearful situation in your life where you might have felt helpless or you might have felt like you were in a great deal of danger and you weren't able to process how to avoid that in the future. Those smaller traumas can also be just as devastating with a lot of these amygdala-based conditions and concerns. So even if you feel like, oh, I don't have PTSD or I don't have like a big major ACEs trauma, I would still look into some of these therapies because trauma is much more ubiquitous than anybody ever realized in the past. And lots of things can cause a trauma response beyond what we consider, big T trauma. So something to consider. But yeah, a lot of this is coming out of the VA, they're a big supporter of psychedelic assisted psychotherapy.
All right. Anything else, Jim? You
My
always have great questions.
take home is that I love that reassure your body that you are safe. I think that's so important, and that it might be the breakthrough.
I think, that's a really great way to summarize it. It is, it's breaking apart that fear and that pain. It really does just come down to reassurance that you are safe, however you can do so. But a therapist can be very, very effective. Sometimes you need that outside perspective because we've so deeply normalized the pain state. And so you kind of need those outside eyes to help you see the evidence that might be missed right now. So absolutely. It's a beautiful way to sum it up.
Yeah. I love your excitement and thank you so much for being with us tonight. I've heard you in other venues and you're just fabulous and you're so exciting and it's good and hopeful. I appreciate that. Thank you.
Yeah.
I'm just the messenger for a very hopeful science. So I'm glad that I'm doing so and giving it the justice it deserves, because right now this field is really on fire. And I think that it's going to have some really rapid benefits for the folks that are dealing with these issues. So hopefully very soon you guys will see a really big change in available therapies for you and how your pain is understood by providers and others just across the board. So I'm very, very hopeful and things are really looking in that direction.
All righty. Well, Dr. Ranes, thank you for all this great information. As always, we will have this video pinned to the top of our Facebook timeline for easy access if you want to watch it again. And we will also add it to our YouTube channel. We will also add a link to the presentation there as well. It is in the chat, it is in the description, but I'll make sure that you all can find it if you misplace the link. So this was our April Facebook Live. Our next Facebook Live will be on Thursday, May 11th. It will be the rescheduled Facebook Live with Cynthia Toussaint and John Garrett. Well, they will discuss everything from caregiving to advocacy to having CRPS and cancer. So you definitely don't want to miss that one. If you have any questions for us, if you need a support group, if you're looking for a new physician, if you want to attend one of our many events that we have this spring and the summer, or if you want to tell your story on our blog, remember we are looking for stories focused on remission. Please send us an email at info@rsds.org. You all have a great evening. Thanks, Dr. Ranes.
Thank you.
Great. Thank you, Alexis.